Thank you. Thank you very much, everyone, for the invitation. I was catching up a little bit before on your seminar, and it seems like you have done a fantastic job. So I'm really pleased to be part of it. What I've been asked to cover is surgical techniques for off-pump atrial fibrillation ablation. In the next 15, 20 minutes, I'm just going to do a little overview and cover some of the most recent data that we have on this topic. These are my disclosures. So the objectives of this talk would be to review the current surgical techniques for off-pump AFib ablation and really concentrating on the thoracoscopic bilateral ablation and the convergent procedures, to review the safety and efficacy of off-pump AFib ablation procedures. We're going to review the importance and benefits of left atrial appendage ligation besides stroke prevention, and identify which patient population best benefits from an off-pump epicardial ablation strategy. I just want to talk in general about the surgical treatment for standalone atrial fibrillation in North America. So this was a review of the STS database from 2011 to 2017 of how many standalone surgical ablation procedures were performed and which type on-pump or off-pump techniques were used. So from 2011 to 2017, there were 7,239 patients that had a standalone ablation. And there were two versions on the databases, but they looked at the ones that they had a complete set of information, and that brought it down to 3,893 patients. The majority of these patients for standalone AFib are done on an off-pump fashion, around that 3,252, on pump 491. And the conversion rate, which was either you started with an off-pump and had to change the incision from thoracoscopic to sternotomy, or you converted from off-pump to on-pump, was 150 patients. And what they demonstrate here is that there has been an increase in the number of off-pump cases, around 7% per year, and total ablations for standalone AFib. Again, within the big scope of AFib ablation, this is a very small number compared to catheter ablations done in the United States. So I just want to use just some terminology as we move through this topic. The evolution of techniques, as everyone knows, the gold standard is Cox-Maze. There's a Cox-Maze 3, then a Cox-Maze 4. And in the epicardial ablation, there has been a migration between the initial Wolf mini-maze to a thoracoscopic maze to a dual endocardial epicardial ablation. And there have been several trials looking at that kind of technique with the deep trial, the SEAS and the hard cap, and I'll go over that. And the more recent technique, which is this converge approach, where you are basically taking the posterior left atrial wall and ablating them. So in general, when we look at what epicardial options we have, or when we do an epicardial procedure, the goals are to do some posterior wall debulking ablation. This could be done with a subcyphoid access. That's basically the convergent procedure, and I'll cover that in a little bit. And the bilateral thoracoscopic approach, where you can do a pulmonary vein isolation from both the left and the right thoracoscopic approach and add some lines, a roof line, a floor line, and then you can get a little bit more involved if you want to divide the ligament of Marshall, and obviously close the left atrial appendage, as mentioned in the previous talk. The importance of the left atrial appendage closure, especially in patients that are going to undergo surgery. So why surgical off-pump? I mean, there is catheter ablation done with many forms, whether it's RF, cryo, laser, and the more recent pulse field ablation. So all of these techniques are used daily in catheter approaches without having to have surgery. But the reason that I think some patients would benefit from surgery is for the following. When you look at catheter ablation alone, it has limited effectiveness in advanced AFib. So when you start looking at the patients who have long-standing persistent AFib, the results are not as good. These are different trials, just looking at the efficacy And in this catheter ablation trials, you see it's around 50 to 60%, and that was with no patients with long-standing persistent atrial fibrillation included on the trial. As you start adding those patients into the trials, then you see the efficacy goes down. And also there is data demonstrated that there's transmural insufficiency and reconnection rates. So these are patients that underwent catheter ablation. And then when you come back later, you see that there has been some focal reconnection between around the pulmonary vein lesions. And depending on the study, these are the percentages of reconnection. So again, the endocardial approach is beneficial for a good number of patients. However, there are some patients that still have failures. And this is because there are limitations to the endocardial approach. Obviously, the complexity of the left atrial wall, there are different thicknesses and different muscle architectures within the posterior wall. The thicknesses change, and the efficacy of endocardial, once you start getting over 4 millimeters, either you run into having some complication rates, and it is difficult to achieve transmural lesions in those patients. There are also other contributing factors. There's known pulmonary vein triggers. There are substrate changes within the left atrium. There are epi and endo connections that occur, as we show, some reconnections, and also epi-endo disassociation. You can create a lesion in the endocardium, but you still have some waves that go in the epicardium of the heart and still having failure of maintaining sinus rhythm. So for all these reasons, endocardial ablation, especially in more advanced atrial fibrillations, become less successful. So who should be considered for this hybrid approach, where we have some endocardial ablation, epicardial ablation? And I think as we look at this continuous of atrial fibrillation, when you start with patients early stages, small left atriums, pulmonary vein isolation alone for these patients is probably a very effective technique. And as you start seeing that the patients start getting a little bit bigger atriums, failures of initial ablations, and you go from the paroxysmal to more of the persistent and long-standing persistent, I think that this is where this hybrid strategy should be considered, especially for these patients with long-standing persistent AFib. So let's review some of the outcomes that are available. So this is basically just looking at endocardial catheter studies. They all looked at doing some pulmonary vein isolation plus adding some low voltage ablation in the posterior wall to increase a little bit more of the posterior wall isolation. Erase AFib actually show a benefit when you added the ablation of the additional ablation of the posterior in addition to pulmonary vein isolation. But these two other studies, Stable and Kaplan, did not show any benefit. So again, left atrial posterior wall ablation using endocardial ablation alone has limitations. Some of the arguments of the Kaplan of why this patient didn't benefit, these patients were early. There were patients who, this were first-time ablations. So this is that initial patient that has a good substrate, and adding more than just the pulmonary vein isolation may not add any benefit. Looking at the 4 major trials looking at hybrid to treat persistent AFib and long-standing persistent AFib, the most recent one is actually cease AFib, which the data just came out recently. But if you go by the trials, the Converge trial is a subxiphoid approach. Patients that got pulmonary vein isolation versus a hybrid endo and epi, and the patients that had the combined procedure epi and endo, their efficacy of sinus restoration or lack of AFib was better when compared to pulmonary vein isolation alone. When you look at heart cap, same thing, hybrid performs better than catheter ablation alone. Cease AFib, which is bilateral thoracoscopic approach, also demonstrated the hybrid arm doing better than the catheter ablation. And the DIP was a non-randomized. These are the results for that. Specifically, the convergent approach, basically the strategy was for the hybrid patients, they would get epicardial and endocardial lesions. You see here where the lesion sets, which ones are done endocardially and which ones epicardially. And then for the randomized two patients that only had endocardial ablation. So basically, these blue lines here are basically what is added with the epicardial using the convergent procedure. And when you look at the sub-analysis of that trial, if you look at antiarrhythmic drug usage after hybrid AFib ablation, you can see that there was a significant lower class 1 and 3 antiarrhythmic usage at 12 months compared to baseline, and significant lower antiarrhythmics at 12 and 18 months for the long-standing persistent atrial fibrillation. So overall, you show a difference. But when you look at that more complex, long-standing persistent, not just the persistent ones, there was a significant improvement for the patients that had the hybrid procedure. This was a 2-to-1 randomization trial. When you look at quality of life, again, there was also benefits in quality of life for the patients that had the hybrid procedure compared to the endocardial ablation alone. So this is total evidence. These are obviously for the convergent or the converge trial. This is the initial trial, and these are single center series, but anywhere between 60-70% a range in success when you do epi-endo on this more complex patient population. Looking specifically at hybrid ablation doing the bilateral thoracoscopy, there's a large Belgian experience. They published their 10-year experience, so from 2010, 2020. This was doing a posterior wall box and pulmonary vein isolation using the synergy clamps and the atrial pens and excluding the left atrial appendage in 76% of them. 20% were paroxysmal, 21 were persistent, and the majority were long-standing persistent. Complication rate, 12.5%, no different. And so when you look initially, you have a 77% in the first year. And as time goes by, these numbers are going a little bit down, which is what we have seen on all series, where it's other surgical series or catheter ablation. But the long-term atrial arrhythmia-free survival for that was 47.5 with a mean of 5 years. This is a nice review of the literature looking at all analyses of hybrid approaches. And here, basically, you have sort of the multiple lesion sets as shown before, but basically it's a pulmonary vein isolation with some posterior wall isolation and left atrial appendage closure with some lines there. These are different devices that can be used for this type of procedures. And what they did is they look at by which devices were used. So when you compare different devices, AtriCure, Cobra, Medtronic, and Contact, there was statistically significant improvement when the AtriCure systems were used. Obviously, this data is difficult to compare one to the other. But also when they look, if the left atrial appendage was excluded, actually the success of sinus restoration was better. And when you tested for exit block, those trials that had more invasive assessment did better. So overall, sinus rhythm maintenance of 79% and 71 with and without antiarrhythmics at a mean of 19 months. And again, this is a meta-analysis taking many studies. The complication rates were around 6.5%, not much different. A lot of these complications for these patients is pericardial effusions after and management of that because of the significant pericarditis that these patients get. There was no difference in rhythm outcome whether the catheter ablation was performed immediately following or stage. So again, there's a lot of talk of should we be doing these procedures at the same time, do the epicardial ablation, endocardial in the same sitting, which makes it very complex for many centers to do that. But there was no difference whether it was done at the same time or not. And excluding the left atrial appendage continues to be shown to not only prevent stroke, but improve left atrial, improve sinus restoration. And based on the studies, basically now there's a 2B indications for patients with symptomatic persistent atrial fibrillation refractory to antiarrhythmics. A hybrid epicardial endocardial approach may be reasonable. So this is the first time that we have some of sort of an indication for doing this kind of procedure based on the trials that I just mentioned. So I'm just going to review a little bit of the surgical approaches and just use two animations to demonstrate both the bilateral thoracoscopic and the convergent approach. But basically here there are different clamps and a clamp technique. This is using the fusion technique, which is this catheter that you can wrap around the atrium. And then this panels here is more the convergent using the EpiSense system. But these are the different clamps, and this happened to be AtriCure. Medtronic has other ones. It's like Cobra. There's different technologies and then different clip systems depending on which technique you're using. So this is an animation looking at the subxiphoid convergent approach. So you make a little incision subxiphoid. Some people will remove the xiphoid process. You get this pericardioscope and get into the behind the heart, and you want to get to the in between the diaphragm and the pericardium stay posteriorly, and then you dissect the plane to get behind the left atrium. You want to go and expose and see the inferior vena cava, and then move to the right inferior and superior pulmonary veins, and do the same on the left side, so you get exposure to all that. Once you get that completely visualized, then you begin your procedure, and I'll show now. There's the device. You want to kind of bend it in a way that you can hug that posterior left atrium, and then you start your ablation sequence from the right pulmonary veins, and you move and overlap. A lot of times you have to make two lesions to get more of the back wall, and then you continue that overlapping the lesions, and then you move from the from the right pulmonary veins to the left pulmonary veins, and then you can actually test and sense and make sure that you have isolation. Some people are adding a left thoracoscopic approach, putting a left atrial appendage and also doing an ablation to the left atrial appendage. And in some centers now, they're using a robotic technique where you can do this robotically from the left chest. This is the bilateral thoracoscopic approach. It starts with a right thoracoscopic approach. So basically ports are placed, and then pericardium is open. And then basically you are isolating the right superior and inferior pulmonary vein. This is a dissector that allows you to get a little, you'll see now, so you can pull the clamp around it using either a vessel loop, or you can use one of this, a right aerobic catheter, which is attached to the device. Then you come around and do the pulmonary vein isolation. There is a lot of kind of differences in how people do this, how many applications, 3 applications. Some people do a double technique, but ultimately some kind of sequence where you then determine if you isolated the pulmonary veins. And then you put the TE probe so you can see where the esophagus is, and then you take the cool rail to kind of move behind the heart behind the left atrium, and you want to avoid contact with the esophagus. So the cool rail then creates and then use saline before you detach the system, so you prevent injury to the esophagus. So you do that on the right side. Once you're done with the right side, then you move to the left side and basically repeat the same process, and then add the left atrial appendage lesion, as well as the closure with the clip or whatever technique you want to use. The left pulmonary veins, they tend to be a little bit that cuff tends to be a little bit thicker, and sometimes you need a few more ablations on the left side to achieve success in transmurality. So again, using the cool rail to go on the other side and do the same. And I'll advance it here. And now you're just making a lesion on the left atrial appendage. And then just pull a clip.
Dr. Rodriguez,
yes.
That's very interesting. We just need to move to the live transmission from the King Salman Cardiac Center,
sure.
with Dr. Mohammed Rashedan. If you have just 1 minute with take-home messages, and then we'll come back to you during the case for more discussion points.
Totally. So let me do. I mean, if you want to go to the live case, and then I can hang out for a little bit, and maybe just if you want to come back, if you want, I can go to the conclusions, and then we can come back if you have any other points. Do you want to do that?
Go to the conclusions, and then we'll
okay. And
please stay with us during the live case. We will need your input during that as well.
So anyway, so I basically, in conclusion, endocardial ablation alone for patients with AFib, especially the ones that are persistent and long-standing persistent, because they have limited effectiveness because of epi and endo factors, as well as the pulmonary vein triggers, should be considered for hybrid endo and epicardial off-pump techniques, because the restorations, sinus restoration has been shown to be better. I can comment on this a little bit later, but left atrial appendage closure, besides stroke prevention, also helps to improve sinus restoration. And especially in patients who have left ventricular dysfunction, those patients benefit from sinus restoration and AFib ablation. Those patients should be also considered for this type of approach, because for the most part, endocardial ablation alone is not sufficient. So the patients with long-standing persistent AFib and persistent AFib, especially the ones who have depressed LV functions, are probably the ones that would benefit from this hybrid off-pump strategies the most.
Thank you very much.
Thank you.